Welcome to the Deep Dive, your shortcut to being well-informed. Ever wondered why removing, a seemingly simple mole can involve such precise medical language? Or maybe why the final bill for procedures that look similar might actually differ? Today, we're taking a deep dive into, the really fascinating world of CPT coding for lesion excisions. Now, CPT, current procedural terminology for anyone not totally immersed in the medical field, it's basically the universal language healthcare providers use.
Right, for procedures, billing, records. It gets everyone on the same page. The surgeon, the coder, the insurance company.
Exactly. It sounds super technical, I know, but we're going to pull out the most important bits, maybe some surprising facts, some practical insights too, just to show you how crucial all this precision really is.
That's the plan. Our mission really for this deep dive is to properly unpack the guidelines. We're talking both benign and malignant skin lesions. We'll define what a CPT excision actually is, figure out which services get bundled in automatically, and maybe the most important part, nail down how to accurately measure and code each lesion. You might have a few aha moments because it's often trickier than it looks.
All right, let's get into it then. Let's unpack this complex area of medical coding so you can walk away with a hopefully really clear understanding of the nuances, why every millimeter truly counts. So before we even get near the codes themselves, we need the basics, the definition. What does the CPT codebook actually consider an excision of a lesion? I mean, it feels obvious, right? Cut something out, but I suspect it's not quite that simple.
You're right to suspect that. It's very specific. An excision for CPT coding is defined as the full thickness removal of a lesion.
Full thickness.
Meaning it goes all the way through the dermis. And crucially, it includes any surrounding margins needed. So it's a complete removal down to the deeper tissue layers. It's definitely not, say, a superficial shave biopsy. That's a different depth, different intent.
Okay, so depth is key. Full thickness. But you also mentioned margins. What exactly are those? Why are they so critical to this definition?
Right, margins. They refer to the narrowest bit of healthy tissue around the lesion that also has to be removed. It's about making sure the lesion is completely gone.
Okay.
The physician judges how wide that margin needs to be. And this is vital, especially for malignant lesions, obviously, but also for some benign ones to stop them coming back. And here's the really crucial part. The measurement of the lesion plus those required margin, that's taken before the actual excision.
Before the cut? Really?
Yes, before the cut. That preoperative measurement isn't just for the record. It basically sets the stage for the coding.
That makes sense. It predefines the scope of work. Okay, so measurement before. Margins are critical. But once the excision's done, does the way the wound is closed change anything about that initial coding? Or is that like a separate thing altogether?
Good question. And no, it doesn't change the excision coding. That's a common point of confusion. The total excised diameter, that's what determines the excision code.
Right.
So whether the surgeon closes it with a simple line of stitches or if it needs something more complex like a skin graft, the excised diameter itself stays the same. It's all about what was removed in that full thickness cut, the repair method. That's a different coding decision, though often related, of course.
Okay, that clears that up. So the size of the spot you see isn't the whole story. It's this excised diameter that really matters for the code. How do we calculate that precisely, for CPT, especially with those margins involved?
Yeah, this is where it gets really interesting and where, honestly, precision is everything for correct coding. The excised diameter is calculated by taking the greatest clinical diameter of the lesion itself.
The widest part.
The widest part you can measure, yes. And then you add the most narrow margins required for that complete excision. So the easiest way to think about it is lesion diameter plus margin on one side plus margin on the other side.
Or lesion diameter plus margin by 2.
Exactly, margin times 2. That makes sure the code truly reflects the total amount of tissue taken.
Okay, that sounds fairly logical in theory. But I can see how even a tiny miscalculation could potentially have a ripple effect.
Yeah.
Could you walk us through a couple of examples just to make it crystal clear, especially how this calculation actually changes the code you'd use?
Absolutely. Let's use some real-world type scenarios, because sometimes just a millimeter or two can push you into a whole different code category.
Right.
Okay, example 1. Malignant lesion, maybe on the trunk. Let's say you have a malignant lesion on someone's back. Clinically, it measures 1.0 centimeters across.
Okay.
But the surgeon decides, okay, for this type of cancer, I need a 2.0 centimeter margin on each side to be safe. So the calculation becomes 1.0 centimeter for the lesion plus 2.0 centimeter margin. plus another 2.0 centimeter margin. That totals 5.0 centimeters.
Wow. From 1 centimeter visible to 5 centimeter coded.
Precisely. The CPT code selected has to be based on that 5.0 centimeter excised diameter. If you only coded the 1.0 centimeter lesion, that would be serious undercoding. Doesn't reflect the work at all.
Makes sense.
Example 2. Benign lesion may be on the neck. Say it measures 1.0 centimeters by 2.0 centimeters. What's the greatest diameter?
2.0 centimeters.
Right, 2.0 centimeters. Now, for this benign one, maybe the surgeon only needs a 0.2 centimeter margin on each side. So the math is 2.0 centimeters greatest diameter plus 0.2 centimeter margin plus 0.2 centimeters margin. That equals 2.4 centimeter excised diameter.
Still bigger than the original 2.0 centimeter measurement.
Exactly. A common mistake here is maybe rounding down or just ignoring the margins because they seem small, but that could mean picking a code for a smaller excision than what was actually done.
Okay, one more.
Sure. Example 3. Malignant lesion, maybe on the face. Tricky spot, say on the nose, measuring 0.9 centimeters small.
Right.
But because it's the face, precision is key, maybe 0.3 centimeter margins are needed on each side. So 0.9 centimeter plus 0.3 centimeters plus 0.3 centimeters, that equals 1.5 centimeters.
So again, a lesion under a centimeter becomes 1.5 centimeters for coding.
Yes. It really shows how even tiny visible lesions can translate to a significantly larger excised diameter for coding purposes, especially when those margins are factored in.
So it's clear, a seemingly small visible lesion can become a much larger excised diameter because of those margins. And getting that calculation right isn't just about ticking boxes. Miscalculate and you could undercode, not reflecting the surgical effort, or maybe even overcode, which could trigger audits. It really hammers home why precise measurement and documentation are just, well, essential for the patient and the practice. That explanation of excision and measurement really sets the stage. So what happens next when we actually go to code these things? Let's start with benign lesions. What are the key guidelines for those CPT codes, the 11-1400 through 11-14-7U range?
Excellent question. Now that we know the what and the how big, let's look at the specifics for benign ones. So codes 11-1400 to 11-1471, they cover non-cancerous things, neoplasms, which just means abnormal growth, scar tissue, fibrous things, inflammatory lesions, mole someone was born with, cysts, that kind of stuff.
Okay.
And here are the main guidelines you need to know.
Lay them on it.
First, separate lesions. This is rule number 1. You have to code each benign lesion separately. Patient has 3 moles removed. That's 3 codes, even if they're close together.
1 code per lesion. Got it.
Second, body area and size. It's not just about size. It matters where it is. CPT groups, body areas, like trunk, arms, legs is one group, scalp, neck, hands, feet, genitalia is another. Then, face, ear, eyelids, nose, lips, mucous membranes, that's the most complex group, usually highest reimbursement. So the specific body area plus that calculated excised diameter we talked about, that combo gives you the code.
Location, 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 and size.
You got it. Third, bundled services. Okay, this is important. For these benign codes, simple closure is always bundled.
Bundled, meaning
Meaning it's included. It's part of the main procedure's value. Same goes for local anesthesia. You don't report those separately. It's assumed you'll do a simple closure.
Okay, so simple closure is baked in.
Right.
But what if it's not simple?
Exactly. That's point 4. Non-bundled closures. If the repair needs more than a simple one-layer closure, specifically intermediate or complex closure, then those repair codes are reported separately. Think layered closure, more complex techniques. Those codes are in the 12,000 and 13,000 series.
Right, because that's significantly more work.
Definitely. Fifth, adjacent tissue transfer, ATT. This is a bit nuanced. If you do a benign excision and an adjacent tissue transfer, that's where you move nearby healthy tissue to cover the defect, codes 14,143 or pseudo, you only report the ATT code.
Only the ATT, not the excision.
Correct. The excision is considered part of the ATT procedure in that scenario. Trying to code both is a common error.
Good to know. Avoid double dipping.
Pretty much. And finally, subcutaneous lesions. If the lesion is deeper than the skin, like a subcutaneous tumor under the skin layer, you generally look at the 20,000 series codes, the musculoskeletal section. The 11-1400 codes are for skin lesions.
Okay, that's a comprehensive overview for benign. Now, moving on to malignant lesions. The 11-1600 to 11-1646 codes, things like basal cell, squamous cell, melanoma, it sounds like a lot of the principles carry over coding each one separately. Body area matters.
Yes, a lot does carry over.
But are there any really critical differences, anything new we need to factor in for malignant cases?
That's a great observation. Yes, many principles are the same, but the distinctions, especially around re-excisions, are incredibly important for malignant lesions. These codes, 11-600, 11-646, cover removal of cancerous skin growths. So, quick rundown. Excision definition. Same as benign full-thickness removal through the dermis, including margins, includes local anesthesia. Check. Separate lesions. Still applies. Each malignant lesion coded separately. 2 basal cells, 2 codes. Check. Body area and size. Still determined by the specific body area, same groupings, and the calculated excised diameter. Check. Bundled services. Simple closures still bundled. Check. Non-bundled closures. Intermediate or complex repairs. Still reported separately using the 12000-13000 series codes. Check. Adjacent tissue transfer. ATT. Same rule. If done with an ATT 14000-14302, you only report the ATT code. Check.
Okay, so far so similar. Where's the twist?
The twist comes with re-excisions. This is where timing is absolutely everything, and it often causes confusion.
Ah, okay. Let's hear it.
Right. Scenario 1. The surgeon does the initial excision, sends a sample for frozen section pathology during the same operation. The path report comes back while the patient is still on the table. Margins aren't clear, so the surgeon goes back in immediately and takes more tissue.
Right then and there.
Right then and there. In that case, you use only one code, and that code is based on the final, widest excised diameter needed to get clear margins. You don't code each pass the surgeon made. It's all considered part of getting the job done in that single surgical session.
One session, one final size, one code. Makes sense.
Now, scenario 2. The initial excision is done, patient goes home, pathology comes back later, maybe the next day, showing positive margins. So the patient has to come back for a separate procedure on a different day, specifically to widen those margins.
The second surgery.
A second subsequent operative session. In that case, you report the appropriate 11600-11646 code again for this re-excision. And importantly, if this happens during the post-op period of the first surgery, you append modifier 58.
Modifier 58. What does that tell the payer?
It signals that this second procedure was planned or staged or resulted from the findings of the first one. It distinguishes it from, say, a complication or something totally unrelated. It shows it's a separate necessary step in the treatment plan. It's not just a coding thing. It reflects a different clinical pathway, consent, scheduling, billing, all distinct from the first op.
That's a huge difference. Same day, correction versus planned, second stage. Got it. Anything else specific to malignant?
Just the same point about subcutaneous lesions. If it's a malignant tumor under the skin, not originating in the skin, you're typically looking at the 20,000 series again.
Okay. That re-excision distinction based on timings, same session versus subsequent session, feels incredibly important. Get that wrong, and it impacts reimbursement, records, everything. It really shows how precise documentation isn't just good practice, it's absolutely critical. We've hammered this point a few times now. Simple closure is bundled. For someone maybe less deep in the CPT weeds, what does bundled mean in plain English? And why is recognizing that so vital?
Right. Bundled basically means the work involved in doing a simple closure is considered an inherent expected part of the main excision procedure. You can't really do an excision without closing it somehow, right?
True.
So CPT says we're not paying separately for that basic closure. It's already factored into the payment for the excision code itself. Simple repair, by definition, usually means a superficial wound involving just the top layers of skin, maybe a bit of tissue underneath, closed in a simple single layer. It also includes the routine stuff like stopping minor bleeding, hemostasis, and giving local anesthetic.
So it's the standard finish to the job.
Pretty much. And forgetting that it's bundled is a really common coding mistake. You try to bill separately for a simple closure on top of an excision, it'll likely get denied or flagged.
Okay, so simple stitches, one layer, basic stuff that's included in the excision code. But you mentioned if it's more involved. If the surgeon has to spend more time, use more skill, that's when we can report the repair separately.
Exactly. That's the crucial distinction. If the wound needs layered closure, closing deeper tissues like subcutaneous fat and fascia before closing the skin.
Okay, with multiple layers.
Yes, or if it involves significant undermining that's freeing up the skin edges from the underlying tissue so they can be brought together without tension. If either of those is needed, it bumps it up to an intermediate repair. It's clearly more work than just a simple stitch-up.
Right. More complex technique.
Definitely. And then if it gets even more complex, say, the repair involves exposing bone or cartilage or tendon or requires extensive undermining, or it's in a really tricky anatomical area like the edge of the lip, the vermilion border, that qualifies as a complex repair.
Okay.
Both intermediate and complex repairs are separately reportable using those codes in the 12,000 and 13,000 series we mentioned. Why? Because they represent significantly more surgical work, time, and skill beyond that basic bundled simple closure. Documenting why it was intermediate or complex is key here.
That makes perfect sense. The code should reflect the actual work performed. Simple closure is standard. Anything beyond that requires specific coding to show the increased complexity. Wow. This deep dive has really shown that CPT coding for lesion excisions is, well, way more nuanced than just removing a spot. We've covered the definition, full thickness removal, the absolute importance of margins for calculating that excised diameter.
Lesion plus margin times 2.
Right. And the distinct guidelines for benign versus malignant lesions, especially that critical difference in handling re-excisions based on timing. It's so clear that every single detail in the clinical documentation directly shapes this sort of official language of healthcare.
Absolutely. Understanding these guidelines, calculating that diameter correctly, knowing what's bundled like simple closure, it's just essential. Essential for accurate billing, yes, but also for making sure the procedures are documented correctly. It's all about clarity and precision in describing the actual clinical work and the care the patient received. And that feeds into accurate health records, even public health data down the line.
So what's the takeaway for you, our listener? Maybe you're a coder trying to navigate the CPT manual. Maybe you're a healthcare provider aiming for flawless documentation. Or maybe you just find these complex systems interesting.
Which they are.
Right. It really highlights the huge importance of every detail. Accurate coding affects insurance claims, practice finances, yes, but fundamentally it ensures a patient's medical history is crystal clear for any future care they might need. So here's something provocative to chew on. We've seen how tightly the definition of excision and that excised diameter calculation are linked to the final CPT code. How might just a tiny difference, maybe a millimeter or two in measuring a margin, drastically change the financial side of a procedure? And what does that imply about the pressures and practicalities of accurate record keeping in a busy clinic, right, where patient care decisions and billing intersect?
That's a weighty question. Definitely something to think about.
Thank you for joining us for this deep dive. Until next time, stay curious and keep learning.